Good afternoon. The seminar of today will be presented Ruben Muñiz. He's a friend for me and an expert in the work with the patient institutionalized, with demented institutionalized patients. He's working in the care of this type of patients for several decades. And he has performed some research, for instance, on the different non-pharmacological treatments for demented patients, and in the elimination of the
physical and chemical restraints. Physical and chemical.
Physical and chemical restraints. And he has also designed and working on an original translation from the cognitive stimulation to the emotional stimulation. He has designed a method to stimulate the emotions of this type of patients. And he will present today the emotional stimulation, the rationale, the method, and some preliminary results. And I can't overlook coincidence today when he was invited to present this seminar several months ago. This date was the first date that was available, but we have had the coincidence between the presentation of the extension of our foundation with the laboratory of neurophysiology and neuromodulation, and the interesting introduction of the emotions into the targets, the therapeutical targets. So both things have coincided in the same date. He will present his method and his first results. I think that it will be interesting for us to open our minds to new experience and new experiments. So, Ruben, please.
Yeah. Yes. Okay. Thank you so much, Teodoro. Good afternoon, everybody. I'm going to talk about emotional stimulation therapy, and I have to start. First, we have to talk about the context of emotional stimulation therapy and clinical pertinence. Why do we need something like emotional stimulation therapy? I'm going to talk about the underlying theoretical model of emotion that we have in T2E. And I will give you an overview on the structure of T2E sessions, which is different from conventional CST, or cognitive stimulation therapy sessions. I'll give you an overview how we research and development these sessions, how we validate them, and I'm going to show you the manual. I have a sample of the manual here. We can just have a look at it if you want at present. So it is a manualized intervention. The manual is not published, okay? the manual is only available to those that do T2E, those that yeah, it's internally published, but the public cannot buy it. So this is only available to those that do the training. Okay. And as Teodoro said, I'm going to give you incipient data on outcomes. In 2011, we published an international paper or an international the conclusions of an international study, which was basically a systematic review and a meta-analysis of non-pharmacological therapies that were applied to dementia. It was the first time that such a huge undertaking was published. We started out the project in 2004. Non-pharmacological therapies in those days were regarded as something of low class, very questionable and all that. And we wanted to see whether there was some use to them. And first we defined what a non-pharmacological therapy is by consensus methodologies. And then we analyzed all the fields of non-pharmacological interventions. We found obviously that some non-pharmacological interventions are meaningless or do not produce any benefit. Some are even iatrogenic. Some are very positive for the patients or for the caregivers. And all these interventions implicitly work with emotions. If you do cognitive stimulation therapy, you don't want your patient to be frustrated or angry, or you want people to be as happy as possible. If you do psychotherapy, you don't want your patients to be to feel bad and so forth. So there is always, in all these interventions, there is an emotional underlying objective. However, the emotional objective is pretty much general, right? You don't have specific emotional objectives. So there is a lack of emotion-specific non-pharmacological therapies. To understand emotional stimulation therapy, you have to understand you have to deeply understand cognitive stimulation therapy. Teodoro is one of the co-authors of a series of papers that we published since 2004. And we published the longest randomized controlled trial on cognitive stimulation that has ever been published in the international literature. And we have also manualized our intervention. This was we would say maybe an enriched psychomotor cognitive stimulation therapy. We had about 108 sessions. So we covered the entire year. We had leitmotifs for each month, and we scanned with our intervention. We scanned memory, attention, language, function, calculus, orientation, and all that. And we did the intervention the pretty normal way, standard way, with a standard procedure. And initially we published results to 1 year, and to 1 year results were pretty pretty normal, I would say. So in basic ADLs, after 1 year, there was a benefit of the intervention regarding the control group. It was it was pretty significant, and in basic ADLs, after 3 years, there still was a gain of this cognitive stimulation therapy. in instrumental ADAs, which have a stronger cognitive component, after 3 years, the effects were lost. That's important. So we know now, at least our study says that activities of daily living that have cognitive components only last for maybe 2 years, but not more. However, and that was the reason why we had very long discussions internally, something totally unexpected happened, and that is that that although the CST group performed slightly better, cognitively speaking, after 2 years, the curves of the control group, which was basically usual care and no cognitive stimulation, this is a design that nowadays would not be replicable because ethically it would give problems. What happened is that after 2 years, the control group more or less stabilized for a while, whereas our treatment group performed worse than the control group, right? Yes. Well, I've seen your face. So how is this possible? This goes against the standard paradigm. If you do cognitive stimulation, if you have a believer in your plasticity, then how is it possible that the treatment group performs worse than the control group? And we slept for years on these results before we published them, because in the group, my colleagues were uncomfortable publishing these results. Because how can you present this? I mean, this totally goes against the standard model of cognitive stimulation therapy. However, one day I remembered the post-polio syndrome. The post-polio syndrome is something that is similar to this. So if you have people with poliomyelitis and you train them, they become stronger than those that aren't trained. However, after 10 years, 15 years, those that have been strengthened by training for 10 or 15 years, all of a sudden get weaker than those that did not do any training. So there might be, I hypothesized, or we hypothesized, that there may be a limit in axonal or plasticity. There's like a counter that you can make a limited number of new synaptic spikes, and then after that, there's nothing more to gain. So eventually we published the data because the rest of the data was all correct. So there was no reason to think that our data of the cognitive domain were wrong. So we published it. And as you can imagine, this is our least referenced paper. Nobody cites this paper. It is very incorrect, politically incorrect or scientifically incorrect, but these are the findings. Okay. In the first year of cognitive stimulation, what we see is that depression improves for those that do cognitive stimulation, and it gets worse for those that do usual care. There's also a benefit in behavioral psychological symptoms of dementia. You see that the treatment group performs much better than those that get usual care. So does quality of life. Quality of life also increases significantly. And we checked for BPSD drugs, and our treatment group receives less BPSD drugs than the control group. So the improvement in BPSD was not applicable to, or could not be impinged on the drugs. Another, well, when we shared these data with other researchers behind the scenes, in the hallways of the Congress, not in public, other researchers shared with me the feeling that there was a big problem with cognitive stimulation. That results were not as impressive as we thought, and that there were also some negative problems. Alexander Kurz, he is a German researcher. He regrettably died very recently. I was talking to him about our results, and he coincided fully with me. He had done amazingly well done, methodologically speaking, amazingly well done studies, and he came to the conclusions with his own research and with meta-analysis that cognitive stimulation is not much better than cholinesterase inhibitors or than memantine, right? With all these data, we published once what I called the responsiveness to therapy model. And as far as I see it, if you look at our results, you can envision it from the perspective of the neural populations. So if we do, for instance, motor stimulation in Alzheimer's disease, this is a GDS from 1 to 7, the motor domain is the domain that responds best over the duration of the illness. The cognitive domain is the domain that is the populations of neurons that respond worst to non-pharmacological therapies. Neurons involved in function, maybe procedural memory and these things, they are not as fragile as those neurons involved in higher cognitive functions. They're still more. They have more therapeutic potential, and then it goes down. So the emotional domain is the domain that appears to be more profitable to impinge on with a non-pharmacological therapy, and this may have something to do with the pattern of lesions in the case of Alzheimer's. In the case of Alzheimer's, the first lesions of tangles and plaques appear in prefrontal lobes, in the endothelial areas, in limbic systems, and more on the left hemisphere than on the right hemisphere. And when you take babies, for instance, babies usually develop the right hemisphere first, and it's only after the 4th year of development that the left hemisphere starts developing. So, and this, there's a number of studies that show that we have a little bit less tangles and plaques on the right hemisphere. So emotional processing is basically probably a large, the brain as a whole is probably involved in this, but the right hemisphere is probably less damaged by Alzheimer's disease, and this may be some other conjecture that we could include in the way we designed T2E. So our therapeutical target is mood. For that reason, our data show that cognition is not very profitable to put energy into cognition, because you only have 1 year of benefits. That it makes only sense for 1 year to try and improve cognition, and only in early stage dementia. You can do ADLs for 2 years, basic ADLs. It is worthwhile pushing that even up to 3 years, but the emotional domain is possibly the most profitable, and this is the foundation of T2E. If we want to talk about emotion, we have to talk about consciousness, which is a little bit of.
About the fact that they are still getting worse, even more than the controls.
Yes.
What is your biological explanation for that? What you, because I don't really understand the similarity with the post-polio syndrome. So
Oh, okay. Yeah. The biological conjecture, I would say, because it's only a conjecture, is that if you do cognitive stimulation, you are demanding extra work from a special population of neurons. You are stimulating the brain in prefrontal areas, in calculus, and all the areas of higher cognitive functioning, right? Do we agree on that? If we do cognitive stimulation, that when we do cognitive stimulation, we require the work of these populations of neurons. Do we agree with that? Yeah. Okay. So our belief was that if we stimulate and made these populations of neurons work, we would strengthen somehow these populations. They would bypass those neurons that died through plaques and tangles, right? That was the idea of we had about the benefits of neuroplasticity, because in the early fMRIs, we knew from the late 90s, we knew that in those fMRI studies, when people did cognitive training, bigger areas of the brain started sucking up glucose. So if you have more brain activities, more areas of the brain are sucking up glucose in the case of dementia patients than with normal controls, then that was interpreted as a sign of probable neuroplasticity at work. The conjecture is that neuroplasticity has its limits. If you train an Alzheimer brain in these populations, you can get a iatrogenic effect. And maybe it's because there is no more neuroplastic potential. You have worn it out. You have consumed it. There are limits in chromosomal replication. You have telomeres, and when the telomeres are used up, then there's no more possibility of chromosomal replication. So why should you be able to do neuroplastic activity without end? So our data shows that there is an end. Our data show that the more you do cognitive stimulation, the worse are the results after 2 years. These are the data, and we can conjecture about the reasons or the causes of this. Yeah. Yeah, exhaustion. That's a good word. Yes. Yeah. Mm-hmm.
But my question is, any other data, other similar study with this type, this longitudinal type, that ongoing
with our results. The question is obvious. I mean, but the bad news is that the longest CST studies performed so far have been for maximum of 2 years. We have performed the only study, the only randomized controlled study for 3 years. So we are the only ones that have these data, because the longest studies are only 2 years, and most CST studies have been done for 6 months, 4 months, a year, exceptionally 2 months, and very exceptionally our studies with 3 years. And I'm really sad that nobody has replicated our results, because we stand alone there.
I think so. The question is, how many patients you have on that course?
Yes, we had a total of 84 subjects, so 40 on each branch.
Because I do agree that replication of that result would be very important and interesting.
Yes.
I don't think it's compatible with an exhaustion model. It's more compatible. You need 2 forces. So you could say that there is the training improves the resilience, and at the same time impairs the circuits. So there is a trade-off where improving the resilience works, and if there is glutamatergic excitotoxicity, for example, there will be a point where the 2 forces compete and invert. If it was just exhaustion, they would go to equal. They would not switch. So it's important to know if that switch is a real switch statistically, or is just visually, so we don't have the error bar on that. So I think that the interpretation there changes dramatically depending on exactly that interpretation.
Okay, so what would then be the treatment conclusion of your proposed interpretation?
Well, it better find something that improve the resilience without impairing increasing the neurodegeneration. So, but it will be harder to formally test this idea, of course. I think it's tricky.
There seems to be, I mean, Barry Riesberg has published papers on it, that there seems to be a correlation between higher metabolic activities of neurons and higher appearance of tangles. So the more a neuron works, the higher the probability of appearance of tangles. So I don't know. But this is conjecture. I mean, I don't know whether it's at this point it's now useful to continue this discussion. It's there for having a beer later, which would be a pleasure, yeah, of course. But I think we can discuss this later if you want, because I don't have the answers. I just make the proposals and I make new questions. That's all. So. After what I've shown you, so that CST, so cognitive stimulation therapy, in my opinion, and supposedly I'm an expert in CST because I've published papers in CST. In my opinion, CST is just focusing on the wrong target. CST is targeting on cognition, and cognition is the domain that has the worst outcome. CST has a wonderful outcome in behavior and a wonderful outcome in emotion. So why continue focusing on cognition? Why continuing to focus on maths? Why on calculus, on language, and all these other cognitive functions? Why not focus directly on emotion? So this is the response of the shortcomings. I mean, T2E, emotional stimulation therapy, is the response to the limitations of cognitive stimulation therapy. So, next question we have to answer is, what is emotion? And in our opinion, emotion, at least as how we operationalize the term, in our case, we say, okay, emotion is something that is linked to a conscious experience. You feel happy, so you feel love, you feel hate, you feel anger, you feel despair, right? So this is something that is in the real of consciousness. And there's a lot of conjecture about consciousness as well, but from studies in anesthesiology, we know that probably layer 5 is correlates, activity of layer 5 correlates with consciousness. We know that because anesthesiologists want to cut out layer 5 in order to operate properly. And layer 5 is precisely populated by pyramidal neurons. And pyramidal neurons, they have metronomes in the thalamus that sometimes make them fire synchronously. And when they fire synchronously, then sometimes some research points that this correlates with consciousness. And that means that we could say that consciousness is maybe an electromagnetic phenomenon. So we have an analogical, coherent, and multimodally unified experience. It's not digital, it's not pixelized. We are talking about field theory, and fields can overlay and mix topologically, and cognitions, perceptions, they can be unified in a large coherent model. And I say that that emotions are subject to a similar mix as other conscious phenomena. And indirect evidence is transcranial magnetic stimulation, where you can outrule the electromagnetic fields created by the brain, and then you lose the consciousness because it's completely overwhelmed with the power of these instruments. And other emotional models are from Aristotle to Darwin. After Darwin, we had Paul Ekman, which is a kind of an extension of Darwin. He developed the facial action coding system to infer what people were feeling. Biological models of emotion by Damasio and so forth. Panksepp is maybe, in my opinion, very, very powerful, where emotions are primarily created from the periaductal gray. They go up to the amygdala, basal ganglia, and so forth. This would be secondary emotional processing, and then it goes up to the neocortical areas where you have the tertiary processing, where you have all this complex social feelings and all that. In the 2000s, when we developed T2E, we did not have these sophisticated emotional models. So what did we do? We started using the linguistical model of emotions. We had no other thing in those days. We had Ekman, but we had no finer emotional models. So we used a linguistical model of emotion. Nowadays, Cowan, he has done an amazing job making a map of 600 emotional concepts. And this is a very interesting IT project, basically. I mean, Cowan is I think he's a neuroscientist and an IT expert. I think he worked at Google, and for instance, he mapped emotional concepts and pushed them apart or and clustered them together depending on the areas. For instance, you have disgust, repugnance, feeling to creep out, disappointment, and you have all these emotional clusters. And T2E works more or less with this idea. So conclusions are that emotional taxonomy is a continuum, though it's finite. So we don't have probably it wouldn't make sense to talk about an infinite number of emotions, but there seems to be a continuum. Facial expression, valence, arousal are often insufficient to infer emotions, and this is the limitation of the facts of Ekman. And sometimes a word or an emotional concept may be insufficient. sometimes we have feelings that needs to be described with more than one word or one emotional concept. So the conclusion for T2E is that nowadays we can start publishing. In the 2000s, we didn't even have the proper emotional concepts to publish our results. And I'm going to give you the structure of how the therapy is structured. We have identified around 65 pleasurable affects, empathy, tenderness, illusion in English is, I don't know. We'll have to think about it. It's not easy to translate these emotional concepts. You feel energetic, you feel understood, you feel admiration, you feel fun, you feel strong, you feel comfortable, you feel free, you feel attractive, you feel optimistic, you feel vivacious, you feel triumphant, you feel kind, you feel full. You feel even, and this is an emotional concept that we developed during the COVID years, which is affection without physical contact, because this was very, very dearly needed in those years because people couldn't touch, So we had to make that. And well, we have lots of positive emotional concepts that we do sessions for. So each one of these emotional concepts has its session, and every session is very different from another. So very different to cognitive stimulation therapy, where you usually have the same method. In T2E, you have to do very, very different sessions for all these emotional concepts. Another thing that we started developing, I think it was like 10 years ago or something like that, is we started to do emotional tourism, because we knew that emotions are culturally driven. There is the Bushmen in Africa, they have a concept for the emotion that you feel when you know that a deceased member of your family is watching you in the forest from behind. So this is a very specific feeling, and these Bushmen, they have an emotional concept for that. So there are emotional concepts that differ from culture to culture. So we have studied that too. For instance, the hygge is a Danish emotion. Maybe those of you that visit IKEA, probably you have probably seen the hygge mug. And so we have done sessions for hygge, Gemütlichkeit in German, Geborgenheit, or dolce far niente, Italian emotion, the pleasure of not doing anything. This is a very interesting session for when you are just maxed out. We also have emotions from the Inuit, from the Eskimos, from the Welsh, and so forth. And so we have a very wide array of emotions that we can stimulate, and our patients, our subjects, our customers, our clients can feel all these different emotions. So these are basic emotions, complex emotions, cultural emotions, and we also have express sessions. So we have done that for sessions that don't last like 50 hours or 50 minutes or an hour. These express sessions last for about 10 to 20 minutes the most. So we have, for each one of these emotions that I showed you on the listing, we have from 1 to 3 different sessions that you can choose from. If you want to, for instance, if you want to repeat the feeling of compassion, you have 2 sessions for compassion, you have 3 sessions for happiness, and so forth. And you can use a limited number of, you can also use short versions of these sessions. We have a total of 106 sessions. The book is about 280 pages long, and every session is validated. This is very important. I mean, these are not sessions that some of us has just written down. And no, what we do is when we first identify the emotion for which we want to create a session, right? In these sessions, we have usually between 8 and 12 participants, right? And imagine we want to create the emotion. We want to make people feel triumphant, right? So then we first have to decide how do we define triumphant, because the concept triumphant could be defined in several ways. So we first define it. Second, we think about how can you see externally that somebody is feeling triumphant, because that is very important. If you do a session that makes people feel triumphant, you have to know whether the person is feeling triumphant or not. So for each session, we have external signs by which we could infer that the person is feeling the target emotion. Then we create a strategy how to make the people feel like that, and then we make components in the session for subjects to feel the feeling. And then we do this usually in group settings. It's a group of psychologists, of occupational therapists, other therapists, and myself. And what we do then is we do this in real life. We take the patients, we do our first sessions with the first ideas, and then we come all together and say, hey, this worked, but this didn't, and this other didn't, or this was not very satisfying. So we work on the sessions, and we repeat the sessions in their new format as long as needed. And once we put the session in the manual, it is because the session was positive at least 75% of participants. So the sessions of the manual, this is the manual, yes. The sessions of the manual are validated for roughly 75% success rate with people with dementia, dementia or mild cognitive impairment from GDS3 to GDS5, right? This is our standard. Techniques we use in T2E: reminiscence, focus group techniques, validation, CSD, music therapy, interventions with music, psychomotor therapy, physiotherapy, meditation, relaxation, psychotherapy, blah, 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 and so forth. So this is not a therapy for rookies. It's not for beginners. This is not something that is for everybody. So you need to have at least some experience with patients and with dementia. This is how the sessions are structured. You have your objectives. Well, we give the sessions a name. So the objective is be surprised in this case, and then we define it. We identify the signs. We have a global strategy. We tell the therapists the materials that they have to be prepared, have to be ready when they want to make the session, and then you have the entire procedure. It is very much done like a recipe. You know, a good recipe is a recipe that most housewives or housemen get the same result with. It's so well defined and so well explained that if you do it and you do it and you do it, the three of you are going to get similar results. And this happens. And in real life, this is we have seen this over and over again. So when therapists are taught about how to use the method, even if the therapist does a bad job in the session, it's pretty likely that the target emotion is going to be felt. So it's pretty positive. How do we teach T2E? My first experience trying to convey T2E was in this house, and it was a disaster. I remember because in those days, I think it was like 2007 or something like that. Could it be when you first started working here? When did you open the 2007 or something? Yeah. In those years, I was helping you to organize the symposia for the International Scientific Symposia here in your up just there in front in the conference room you have. And I got to know one of the occupational therapists here in the nursing home, and I said to her, "Hey, do you want to try T2E?" And she said, "Yes." Okay, I gave her the manual, and she started doing it, and she said, "It doesn't work." So just by reading the manual, you are not going to make it work. And talking to Mary Mittelman and other researchers, non-pharmacological therapies, you can write a book this thick and people read it, but still people won't be able to do it. Because apparently the jump from theory to praxis is not everybody excels at. So we saw that the manual needed personal training. We have to train people how to do it, because people come from cognitive stimulation therapy, and if you go with standards of cognitive stimulation therapy, your T2E is not going to work, because you are still going to tell people, "Oh yes, you did a great job. Yes, good. You are going to push people and pull people in order to get results." And this is exactly the opposite of what we have to do in T2E, because in T2E, you're not looking for results. You're not pushing people to make their brain function in the way you want them to function. In T2E, what you have to do is create emotional atmospheres, emotional environments where people can express and live their emotions in a completely free way. So we have to reprogram the minds and the brains of all these psychologists in order to be able to do something totally different. Another thing that we do is we record all the sessions. All these participants, they record their sessions so that we can then, in hindsight, help them to do their sessions in a better way. So this is very important in our methodology. Our training lasts between 6 and 8 months, depending if there are holidays in between. It must be a practicing therapist. We cannot teach this without practice. So you have to have access to patients, to groups of patients. We ask the participants to do at least 23 sessions of a variety of emotions, not only clusters of emotions, but we want the people to get trained in doing all sorts of different emotions. We have to videotape all the sessions. We have to record and evaluate the emotional outcomes. I'm going to show you later how we do that. And the participants have to participate in research and development of new sessions. And now I'm going to honor Teodoro's announcement that we're going to show you some preliminary results. All the participants, all the people that we give the permission to say that they are T2E experts and that we give them the license to do T2E, we expect from them to give an end of course report. So they all have to write, all these students have to write an end of course report. And with a group of 2015 and 16, we made a study. Let's see what, the sample was 72 people, more or less 85, and 27%, well, almost 30% wheelchair users, which means we had nursing homes in here. Half of the sample had Alzheimer's, 20% vascular, 8% mixed dementia, 6% Parkinson's, undiagnosed 16%, and 4% Lewy body dementia. This is the distribution of the Riesberg Global Deterioration Scale. So we are talking basically of GDS3 to GDS5, which is more or less the inclusion criteria of T2E, the ideal inclusion criteria. This is a descriptive baseline: anxiety, a quarter of them; depression, a quarter; 20% agitation or some aggressivity; apathy, a quarter; irritability, and so forth. 2 patients died, 3 dropped out, and 1 therapist changed its job, so the data are not included of this therapist. You see that the academic performance of the therapists was pretty decent. Many had master's degrees and so forth. We had 1 occupational therapy. Nowadays it's a little bit different. We now tend to have more occupational therapists. And the research question was, do participants feel the target emotions of the manual? And to answer that question, we did a pre-intervention patient assessment of all the subjects. All the subjects were more or less covered inclusion criteria. The families or the participants sign is informed consent. Each emotion had from 1 to 5 observable signs, and the therapists had to register observable signs for the end of course report. Sessions were videotaped as usual. Quality control reports was performed by myself, by Ursula Martinez, and Lidia Vázquez. And Lidia Vázquez transferred all the data to Excel. This is how we trained the people. We trained them in theory of emotions, in biophysics, and linguistics regarding. Maybe you got just a flavor of how we train people. I had to be very, very brief beforehand. Practical training. We do self-analysis of emotion. I mean, we need the people to get in touch with their own emotions. The therapists have to learn how to feel. It's not easy to feel. Even for psychologists, it seemed not to be very easy to get in touch with your own emotional life. So we have to teach that. We have to train them to do that. And we help them to organize their sessions and how to evaluate them and so forth. And these are the results. So out of 2,200 observations, where the emotional signs were clearly present. This is out of 57%, where you found clearly that these emotional signs were present, and you had 30% where it could come close to the 70% of success rate that I talked to you beforehand. One as an example. The emotion how to feel comfortable. We defined comfort as a mental or physical ease, or comodidad mental o mental o física. Observable items is that the person has to speak relatively slow and in a calm fashion, with an open and relaxed posture. With another observable sign would be a facial relaxed expression and calm respiration, breathing, very, very calm breathing. This is the way how all the participants checked out for the emotional signs of each different emotion has a different table, because in some emotions you have only one observable sign. So in this one, for instance, we have 1, 2, 3, and 4 different signs. Okay, so and these are the patients. So after the session is finished, the therapist writes down whether the emotional sign was clearly visible, whether it is maybe, maybe not, or whether it was clearly not appreciable. So, in global, from the 20 sessions analyzed, this is a global score of results. So apparently T2E delivers what it says it delivers. It should deliver. For instance, this is the analysis of an emotion which is compassion. Compassion is a very complex emotion. Compassion is an emotion that usually is out of GDS6 reach, because compassion has cognitive components. I mean, if you have emotional identification is easy, because you see somebody that is hurt, and you feel hurt too. That doesn't require a lot. But be compassionate means that you have to understand the person. You have to be able to put yourself into the feet of the person. You then have to have the cognitive ability to desire the best for the person, knowing what it means for the person to be in the best possible situation. So it is an emotion that has lots of cognitive components. So what we see in general, this is a little bit of an exception here, what we had, that usually it works best for mild dementia or mild cognitive impairment. So this is also something that in other replications of the study that we have done, we find it. Delight, for instance, is also very easy to create delight if the stimuli are appropriate. And conclusions. Our original strategy, training a wide array of positive emotions, seems to work. T2E has an emotional precision, I would say, unprecedented. I can say that because I know the field of non-pharmacological therapies. 20 emotions, this is a typo. 20% of emotions get almost 60% clearly arouses what it says. T2E compensates the reduction of emotional granularity or color that goes along with dementia. If you speak with people with dementia, you probably have noticed that the emotional color diminishes with the progression of dementia. Do you agree with that? So what we do here is we compensate a little bit for that. So we keep people feeling positive things for a longer period of time. And what is more important, if you have dementia, to be happy or to be cognizant? Probably being emotionally sound makes more sense than scoring 5 points more in the ADS cog. We also realized that it is fully applicable to nursing homes and daycare units. We now are using it even for multiple sclerosis and so forth. It works very well for GDS 3, 4, and 5. With adaptation, we can go even up to GDS 6. It is also efficacious for mild depression. I'm going to give you a very brief overview of a study done for a patient, for a single case study of depression. It is the non-pharmacological therapy that is most accepted by patients. This is something we see over and over again. Therapists that include T2E in their offer, in their menu, in the homes, they always report that T2E is the therapy most liked by patients. And they even queue and they ask, they want to go there because a patient told them that it was very positive and they enjoy themselves there very much. And this has a lot to do with how we create the environments in T2E, which is a very, very special environment. It's not, has nothing to do with the environments that we can get through CST or other typical interventions like animación sociocultural or so forth. We also have our therapists reporting a lasting relational effects among institutional people with dementia. The thing is that when we do T2E, we have to talk about intimate things. So you imagine a group of 8 people, and they start talking about their passion for love, because this is a session we have. Talk about love and how passionate they have loved somebody. Obviously, you are going to share a lot of very intimate feelings with that group. So you create a lot of emotional bonds with the people. And people that you live with in the nursing home, usually you don't share these things with them. But after 1, 2, 3, 5, 8 sessions, sharing very intimate stuff of your life, usually bonds gets stronger and stronger. And what happens then is that people start feeling better in the home. You know this here from your nursing home here. There are many people when they get into the nursing home, they want to leave. A certain percentage of people who come into the nursing home just want to leave because they don't feel at home. They feel in a very alien situation. They feel depersonalized. They feel institutionalized. And what we have realized is that as soon as these patients make bonds with other patients, then they stop wanting to get out. Then because they find people who are significant and meaningful to them. So we can use T2E as an early adaptation tool for new coming residents. So you don't have to wait for a year until the patient feels comfortable in your home. You just quickly put him into T2E sessions, and in 2-3 months the person is perfectly adapted to the nursing home. These are the therapists who created the results I just showed you. This is Javier Lazaran. This is the scientific director of the foundation. This is myself some years ago. And this is the last bit of research I'm going to share with you. This is done by Jaime Iglesias. He is the professor of psychobiology in the Autónoma here of Madrid. He's one of the few experts in Spain that knows how to use the facial assessment tool. And we have been working with Jaime for a couple of years. And I can't. You have to ask him to do the full presentation. I'm only going to show you the picture of the lady. This woman was a member of a 10-person group of T2E, and she was depressed. She had a depression. She didn't want to live. She was tired of living. It was difficult for her to get out of bed in the morning. She needed a lot of emotional support and all that. Okay, so Jaime with facts, he focuses his camera on the face, and Jaime is an expert in assessing the tension of different muscular groups of the face, and from there he induces what the person is feeling, right? So according to Jaime, this lady is depressed, right? And you see that through the entire session, the woman is showing less and less signs of depression until at the end of the session, she is pretty happy, and out of nowhere, she finds a sticker of a smiley face, gets it, and pushes it on her breast, and she goes out of the session with a smiley face. So you can, with these kind of tools, also assess T2E. And So T2E is going to work very well for depression, for loneliness, creating new friendships, quick adaptation to the institutionalization, and keeps the person experience a wide array of positive emotion. And it's a very demanded intervention, and it's also a relief for therapists. This I haven't spoken about that. Occupational therapists and psychologists who do cognitive stimulation therapy get easily burned out. I've been managing homes for many years, and it was very typical that I got psychologists and occupational therapists easily burned out. After 6 or 8 or 10 years of doing CST, they get burned out. Why? Because they have to put so much energy into the session. They have to keep everybody aware of the task. As soon as somebody sees that you fall asleep, I have to, hey, Emilio, please wake up. What's the task? You know, and it is very, very demanding. When these workers go back to their homes on a Friday, they're just maxed out. They just think of football and beer or something. You know, they have to really relax a lot. And the good thing about T2E is that the best way to be a T2E therapist is just be yourself. You have to just be yourself. That's what we expect from the therapists. That's what we train them to do. So you don't have to put on a professional mask. You don't have to pretend being somebody you are not. You don't have to pretend to be happy all the time. You can have a bad day. And if we want the group of patients to have some positive emotion, and the session goes south because the person because there's somebody who is depressed, or somebody's daughter died, you know, then screw it. I mean, then we just all get sad. So there's no big problem with that. So T2E is something that is very, very rewarding for the therapists. And now we have entire chains of nursing homes that train their psychologists and occupational therapists on this. We have now, I think it's about 250 people. 250 people in Spain are doing T2E around the country. And yeah, if you want to cooperate, to evaluate T2E or to internationalize T2E, we would be very, very happy. If you can contact me easily through Teodoro or through our directly to a foundation. Kiko is here. Kiko he has a T2E license. He's trained, so you can ask him directly if you have some questions, or we can leave it here, or you have questions or remarks.
Any question? Comment? Suggestion?
Yeah, thank you very much. I was thinking some years ago, I'm not a psychologist, I'm a pathologist, I'm very far away from this area, but well, I work with some psychologists here with in the nursing home, trying to start with a pain scale, pain feeling. So I was aware that pain is felt and is expressed very differently and progressively differently in these patients. There are some emotions there that you showed that are related with pain, of course.
Yes.
With physical pain or with other type of pain. So I was thinking your registration methods, I mean, what you have shown relies very much on expression of emotions.
Mm-hmm.
And I was thinking how the expression of all these emotions can be changing along the progression of disease in this patient. Is something that one can have in mind when dealing with the observation of the you show the example of the depressed woman. Is this signs, are these signs the same as in non-demented subjects, or is there any difference in the expression? of
There
emotions?
is, I think that there's both a difference in expression and in subjective feeling.
Yeah.
Yeah. Firstly, you can see it in the exterior expression when you see that over the course of the dementia process, the dementing process, in GDS3, in mild cognitive impairment, people still express vividly with their faces, with their gestures, what they are feeling. When you go to moderate dementia and GDS5, more or less, then you have emotional expression of positive emotions, but it's already weaker. The emotions that are expressed most intensely are usually emotions of negative valence. For instance, anger, because they feel with GDS5, with moderate dementia, you frequently feel that somebody is laughing at you, or you are frustrated and so forth. So there still you have very strong emotions. But in positive emotions, you can see that with moderate dementia, the expression goes down. And then with GDS6 and GDS7, the emotional expression really goes clearly down. And I think it has a lot to do with loss of brain volume. If you probably our theoretical approach is, our conjecture is that in order to feel, you need to have a lot of parallel fibers firing synchronously, and if these fibers are dying out and you have a less amount of fibers to fire, so the intensity of the field is lower, so the subjective experience must be clearly less important. This does not mean that we do have patients that have Parkinsonisms, facial Parkinsonism. Apparently they don't feel, but they do feel. I have not told you, one of the studies that I presented here, we did some other things. I don't have time to report everything. But one of the findings was that people who had facial Parkinson, either because it was mixed dementia, for instance, there were vascular issues besides the Alzheimer's. These people, when you looked at their faces, they were unexpressive. However, if 2 months later you did the Jessavage, when you try to analyze or to measure, to assess depression, then they were less depressed. So it's not a simple thing. It's a complicated thing. But it's now that you talk about expression of pain, I didn't tell you that, but in the first years of T2E, we also created stimuli for negative emotions. For instance, we scared people, to scare them, or to make them feel sad, or these. But we quickly stopped doing that because we realized that they had enough with their illness and their problems, and then we started using Seligman's positive psychology approach. We focus on the positive things, to compensate for the negative ones that they already have due to their dementia.
I wonder whether you have any experience with frontotemporal dementia. This is where there is a profound distortion of
Yes, we do have. In real life, in these groups, it's not. We don't only get the nice patients. We also get people with frontal symptoms, and the results are mixed. Sometimes we can't get them to stay in the sessions, but most of the times it works. I mean, we have different symptoms that these patients exhibit. Sometimes they can't stand still, they are moving out constantly. Others have compulsive behaviors constantly and so forth. But in these cases, what we do with frontotemporal people is we put them usually at the side of the therapist. We have them sitting on the side of the therapist, and each time they want to do something else, the therapist calms them with a hand or does a sign that is before the session. If there is memory still, the therapist makes an agreement with the patient and says, every time I make this, you calm down, or you stay there, or you don't talk, because sometimes it's just there's never-ending talk, or whatever. So we can do something about them. We can include them in the sessions, but not all of them.
Any other comment? I have a question. First of all, I congratulate the systematic work of definition, identification of the sign of every emotion, the validation of the tool of sessions. And if we examine the data that you have presented about the result of this study, you realize that you have found more or less the same data, same results that you have previously obtained in your validation process.
Yes.
So you have demonstrated that the result that you observed
Yes.
obtained in the validation process can be replicated.
Right.
And I wonder whether you have any data on these outcomes. I agree with you.
On these, for instance? No, we don't. It's just empirical for the time being.
Be happy is probably better, much better than have 2 or 3 more points in the other stuff.
Yes.
But you have data on these, let's say, relevant points or relevant outcomes to demonstrate that the therapy, the process has some positive practical outcomes.
Before COVID, we started to do a randomized controlled trial with like 150 patients. And we controlled for this. We controlled for loneliness, for depression, for socialization. We controlled for all that. But after we got the baseline done, COVID began, and we had to abort the project. But we do have the protocol, and I had a look at the figures that we have produced, and they were positive. But the study can't be even published at present.
Heck,
Yeah.
good is like from practical
Yes.
positive outcomes.
Yes.
This is, I think that this could be the demonstration that the therapy is effective
and that the effort is worth doing in the homes, because you have to allocate human resources to do this. Yes, thank you. Yes, this is very inspiring what you just said, and I totally agree. However, there's also something important. Some years ago, we published the non-pharmacological experience scale, and this is not only the clinical outcomes are important, especially on interventions or on drugs that are not penicillin, right? If you have penicillin, you don't even need sophisticated studies, I mean, you quickly see that patients are cured, you know, and that's easy. I don't think that T2E or cognitive stimulation therapy or whatever is a cure-all, and you're going to cure Alzheimer's. So we have to be very, very modest in assessing the benefits of these things. And the cost benefit ratio of these interventions is very, very important. But I have to say that although I'm pretty sure that if we do this if we do a randomized controlled trial, we will have positive findings. We should also bear in mind that the experience of the people themselves in the sessions is of critical importance too. You are a neurologist. You are looking for cures. You know, you are looking for ecological outcomes. You're right, and I share that interest with you. However, we should not forget that it is important for these people to have meaningful existential experiences during these sessions. To me, this is as important as the clinical outcome. You don't go to the movie for therapy reasons. You go to the movie to enjoy yourself and to live your life to the fullest, right?
I accept your proposal, but you have to convince.
Yes, I
people
commit.
to-
You give me the
to make
resources, and we
effort
make the
to
studies.
invest the resource and so on this or on any other
Yeah,
treatment practice.
yeah.
I have a question about the let's call them negative emotions.
Mhm.
So this morning, what Theo was referring to before, we did in the act for the inauguration of the neurophysiology and neuromodulation lab,
Yes.
an experimental.
I witnessed
concept.
it, by the
You
way.
were there.
Yeah, congratulations.
Thank you. So now you know what you're talking.
Yes.
What we are talking about. So of course, there the structure that we use is to use consciously the some negative emotion to get deeper into the positive emotion.
Mhm.
So my question is, because you said before that you also had some experience with your techniques,
Yes.
try to work on negative.
Yes.
So did you combine them so that if you can get a more significant experience when the positive emotion comes after a negative, or you always go either one direction or on the other?
We have a cultural problem in Spain. In Spain, we tend to broom death under the carpet. All negative emotions and feelings, you know, we try to make disappear. In Spain, we usually do not talk about death. I mean, go to any Spanish graveyard. You know, you will see that there are nichos, we say, right? So the dead are there, you know, and the living live their lives. Whereas you go to the United States, to Germany, to other countries, you will see that death is perfectly parks. The dead are in the parks, and you go walking there. So what we do have in Spain is that we have a cultural tendency to, as soon as somebody says something negative, we start to, hey, no, we are not here to talk about ugly things. We are here to talk about the nice stuff, you know. So this is something that Spanish therapists do almost like a reflex, you know. When a patient starts talking about or starts expressing a negative thing, we immediately try to suffocate it, to extinguish that. So we have to train them to let them express all that sadness or all the grief there is, you know, and to be open that it may take the entire session, you know. And then, as you say, then we try to morph it into something positive. And this is standard procedure in T2E. I mean, when we do T2E, ideally the session goes more or less the way we want to, right? If you want to make people feel, for instance, if you want people to feel exhilarated, right? So this is the utmost happiness that you can feel. You can't make them feel like that for more than 3 seconds, right? Because this is a feeling that quickly wanes, right? So we have to build the session up little by little until at the end of the session you get these 3 seconds of exhilaration, you know. However, you have to be open to the fact that somebody might feel very, very bad because something terrible happened, you know. They have to leave the nursing home, you know, and they're very happy here and they have to go, you know. They learned it this morning. So you have to handle that. So we do integrate the negative emotions, although we don't look for them. We don't seek them out, you know. We integrate them just. And there are other things in T2E that I did not mention. We create, for instance, protocols in the nursing home by which we have routines for people to feel well. So the number of techniques and ideas is very vast. So and we try to go beyond the group that does this intervention. So we try to make other people in the nursing home feel better with positive emotion routines, not the negative ones. But the negative ones, I totally agree with you. They should also be taken more seriously and not be ignored like we do here in Spain. Was that it?
Thank you for this interesting presentation.
Thank you for listening for such a long time. Yes. Oh yes, I'm very emotional. Yes.
Experience.
Yes. Thank you. Thank you.